Assalamu alaikum. This lecture, the third lecture on spine, is about spine infections. It includes the specific and non-specific spine infections. Uh, the incidence of pyogenic spinal infections is increasing, possibly due to increased rate of spine interventions. Vertebrae are the most common sites for hematogenously acquired osteomyelitis. Vertebral osteomyelitis may account for up to 7% of all bony infections. MRI has state early diagnosis because MRI is sensitive in detecting bone marrow edema, and edema is one of the cardinal signs of inflammation. And vertebral osteomyelitis commonly presents in delayed fashion in MRI. The mainstay in early diagnosis of spine infections is clinical. Now, pain with painful limitation of spine range of movement is a very important early sign in detecting infection, because MRI manifestations may be delayed after the clinical presentation. Now, structural localization consists of spondylodiscitis, that is infection involving the intervertebral disc and the metaphyseal bone of the vertebra above and below in 95% of cases. Discitis only in 1%, infection of the metaphyseal region of the vertebra in 1%, pyogenic facet erythropathy in 6%, epidural abscess in 2%. So most commonly, spine infections present as spondylodiscitis. The concept of spondylitis in adults originates from the theory that in adults, infection starts in the subchondral bone in the metaphyseal region of the vertebra as a focus of osteomyelitis. Then it spreads into the adjacent intervertebral disc. Usually the metaphyseal region of the bone has high oxygen tension, and this facilitates the attachment of the infective organisms, and adherence and attachment and proliferation of the infective organisms will set up the infection process. Anatomical location of spondylodiscitis involving the lumbar spine in about 50% of cases, followed by the dorsal spine, 25%. The cervical spine has the least rate of involvement in pyogenic spine infections. And the most frequent anatomical site for thecal sac encroachment by epidural abscess is something different. And this is related to the location of the spinal cord and to the diameter of the spinal canal. In the cervical spine, 90% of epidural abscesses manifest in the cervical spine, followed by the thoracic spine, 33%. The lumbar spine are the least because they have capacious canal, and this is in a decreasing order of frequency: cervical, dorsal, and lumbar. While for easy remembering, anatomical location, it from lumbar, thoracic, and cervical, while epidural abscess is in descending from cervical, thoracic, and lumbar. About 40 to 80% of all spine infections are caused by Staph aureus. Less common causative microorganisms include gram-positive bacteria like Staph epidermidis and streptococci. Untreated or medically unresponsive pyogenic vertebral infection often becomes progressive, leading to instability because of the inflammatory process, neurologic deterioration because of the infective granulation tissue and the inflammatory process again, or because of abscess formation, or because of the acute instability because of infection. Intractable pain, patients with infection noticeably present with intractable pain, and this pain is called pain with red flag signs. That is pain even at rest, or pain that interferes with the patient's sleep, and nocturnal pain, and pain associated with constitutional symptoms like fever, night sweat, and pain associated with increased inflammatory markers, deformity, and or death. Any treated infection is dangerous. Now, the key to successful medical management, without surgical interference in a patient with spine infections, is early detection of the inflammatory or the infective process. So, patients detected in the first 2 weeks of beginning of symptoms usually or can be treated successfully without surgical intervention. So stable patients, that's to say patients who have no instability because of the inflammatory process, and patients without progressive neurological deficit can be treated can be treated conservatively, and the principles of conservative management of spine infections is we have to identify the causative organisms. Identification of the causative organism can be done by taking a blood culture or direct tissue culture from the infected region. And this can be done by invasive measures like transpedicular biopsy or tissue culture. We obtain a tissue culture that is cultured for aerobic, anaerobic, gram-positive, gram-negative, and TB bacilli. Identification of the causative organisms followed by appropriate antibiotic therapy, and this is guided by culture and sensitivity testing. Sensitivity testing can be delayed. So we have to start the patient after obtaining tissue culture with empirical antibiotics. Another quick way to obtain bacteriologic diagnosis is by using the molecular processing and like the polymerase chain reaction, but these are non-specific. Now, identification of the causative organism followed by appropriate antibiotic therapy, and this is usually consisting of intravenous antibiotic treatment and with accomplishing of the minimum inhibitory and minimum bactericidal concentration of the antibiotic in the blood and the serum. And the duration of antibiotic treatment varies from 2 weeks to 6 weeks, followed by oral antibiotic treatment. Conservative management can be supplemented by spinal orthosis to decrease pain and stabilize the patient. That's to say, we brace the spine. Up to 50% of patients fail non-operative measures, and they require surgical debridement and the spine stabilization. Now, what are the indications for surgery in a patient with spine infection? A patient with real or impending spinal instability needs spine stabilization to protect the neural structures and to decrease or ameliorate pain. So spine stabilization in the presence of a spine infection is important to protect or prevent neurologic deterioration or compression and to manage or to treat pain. A patient who develops spine deformity is indicated for surgical correction and stabilization. A patient or surgery is needed to establish a diagnosis, especially in a patient with negative percutaneous biopsy. So we can during surgery we can obtain a representative tissue biopsy that can be examined histopathologically and cultured. So culture what you biopsy and biopsy what you culture. A patient with a progressive unrelenting pain, again, surgery is indicated to decrease the pain. A patient who develops neurologic deficit, especially if it is progressive, should be stabilized and with instrumental diffusion. In a patient with sepsis refractory to broad-spectrum antibiotics or those who have failed appropriate organism-directed antibiotic therapy, surgery can help in establishing a tissue diagnosis and in debridement and stabilization. Stabilization, rigid stabilization will burn the infection, and this is important. We treat long bone infective pseudoarthrosis with rigid stabilization to burn the infection. Now, an important topic is regarding spine infections is spine tuberculosis. TB spine is endemic in our country. It should be included in the differential diagnosis of any patient with pain, with vertebral destruction. It can mimic various diagnoses like spine tumor and other destructive spine lesions. The spine is the most common site for musculoskeletal TB, and the thoracolumbar region is the most commonly affected site. The majority have 2 or more vertebrae affected at presentation. This contiguous, that's to say, for example, a patient with TB in the cervical spine might present with TB focus, another TB focus in the thoracolumbar spine, and these are what we call discontiguous, يعني واحد بالcervical واحد بالthoracolumbar. This contiguous spine involvement can occur in approximately 1/4 of the patients. So in a patient with spine tuberculosis, we have to take the whole spine MRI under radiological evaluation. Now, as we said, patients with a spine infection, if they are in the active stage, can be present with pain, and pain with red flag signs. Again, this is nocturnal pain or pain at rest or pain that interferes with the patient's sleep and associated with a painful spasm and limitation of movement. If the pain is associated with malaise or loss of weight or night sweat or other constitutional symptoms like nocturnal fever, what we call evening rise of temperature, again this pain is with red flag signs. So pain, night crisis, stiffness, deformity, restricted range of motion. A patient may present with a large lymph nodes or presented with a pointing abscess, or a patient may present with a neurologic deficit. Now, this type of pain, it indicates serious cause or serious etiology and should be taken into consideration with investigations and management. Now, investigations include complete blood count or complete blood picture, and we get anemia or lymphocytosis in TB. The ESR is raised in the active stage of disease, but frequently the ESR is not helpful in the diagnosis because most of these patients have a disease not in the active stage, or they are taking anti-inflammatory medications or antibiotic treatment that will mask the rise of inflammatory markers. Normal ESR over a period of 3 months suggests that the patient is in a stage of repair or it is in the inactive stage of disease. Now, the mainstay in the diagnosis of a patient with suspected spine TB or TB spine is radiologic. TB bacilli are scant in the TB focus. They are difficult to be isolated, they are difficult to be cultured. If we get a specific type of histopathological inflammation, that is caseating granuloma, a presence of caseating granuloma, even if we cannot detect the TB bacilli, it indicates that this type of infection is tuberculous. Now, radiologically, MRI is the mainstay of diagnosis of spine TB because it is sensitive in detecting bone marrow edema and increased fluid content in the metaphyseal region of the vertebral body. Now, MRI or TB spine usually presents with three patterns of MRI involvement. Infection or disc involvement with paradiscal vertebral metaphyseal involvement. So we get paradiscal metaphyseal tuberculous focus or osteomyelitis. Or TB can present within the center of the vertebral body, and the patient might get, because of the infection and destruction, get collapse or pathologic burst fracture of the vertebral body. TB can involve the subligamentous focus, that's to say below the anterior longitudinal ligament or below the posterior longitudinal ligament, and abscess formation below the anterior longitudinal ligament can track along facial or tissue planes. These patients usually present with abscess, or what we call cold abscess formation, and the abscess can track along these tissue planes and can present in the paraspinal region, or presents along, if the patient has thoracolumbar involvement, it can track along the psoas muscle or the psoas fascia, and it descends down to present in the groin or in the loin, and what we call psoas abscess, or can present in the flank if it is, or it tracks along the quadratus lumborum muscle. TB spine is an anterior disease. That's to say it mainly involves the vertebral body or the anterior spine elements, يعني intervertebral disc and the paradiscal region. So, if the MRI showing involvement of the disc with paradiscal metaphyseal involvement, يعني the metaphysis of the vertebra above adjacent to the disc and the metaphysis of the vertebra below adjacent to the disc, what we call paradiscal involvement, and in X-ray it appears as collapse of the disc space. This is strongly suggestive of an infective process, infection. Involvement of the vertebral body without involvement of the disc in a patient with the red flag signs will direct our attention for another process like tumors. So tumors does not involve usually the intervertebral disc because this is a fibrous tissue component and it acts as a barrier against the tumor involvement. While infections, whether they are pyogenic or TB, they usually involve the intervertebral disc with their proteolytic enzymes and metalloproteases or collagenases that will lyse or destruct the intervertebral disc, or they will cause a nutritional affection of the intervertebral disc because of the involvement of the vertebral endoplates, and as a result we will get the intervertebral disc collapsed with paradiscal involvement, and this is typical of spine or TB infections. Now, TB can involve the posterior elements, but it is rare. It is less than 20% of patients. TB spine can present atypically. That's to say, it can involve only the posterior elements. As we said, TB is an anterior disease. So isolated involvement of the posterior elements, يعني spinous process, the lamina or the pedicles or the facet joints is rare. So isolated involvement with the sparing of the vertebral bodies is rare. A second type of atypical representation is infection confined to one vertebra. And chronic TB infection can transform the vertebra into what we call an ivory vertebra. Ivory مثل عظم العاج أو مثل ivory vertebra. In the X-ray it appears as dense white or dense vertebral body. Now the pathogenesis involves hyperemia with osteopenia due to the hyperemic process, and due to an inflammatory process, because inflammation is characterized by edema, hyperemia, and pain. Infection in the metaphyseal region will cause ischemic necrosis of the bone because or subsequent to peri or end arthritis. The disease itself will cause destruction of the vertebra. Again, this will result in collapse and progressive deformity or gibbous formation. Diagnosis involves increasing, as we said, in lymphocytosis and increased inflammatory markers. ELISA test for antibodies to mycobacterial antigen has a sensitivity of 60 to 80%. Since TB bacilli are scant and cannot be isolated or difficult to be isolated, the TB gene can be amplified with polymerase chain reaction and has a sensitivity of 40%. A chest X-ray might be helpful. Tuberculin test is not helpful in our country because most of our patients or population is vaccinated in childhood. Isolation of the TB bacilli with Z-Nielsen staining or acid-fast bacilli staining. Culture takes 4 to 6 weeks. Lowenstein-Jensen medium. And it is positive only in 50% of cases. That's why it is difficult to isolate the TB bacilli in patients with TB spine. The mainstay in the diagnosis is clinical, radiological, and lab. In a country with endemic involvement of TB, typical radiologic manifestations are adequate to start anti-TB treatment, because delaying treatment will cause to destruction of the vertebral body and deformity or neurologic involvement. The mainstay of treatment TB spine is medical anti-TB treatment, combination anti-TB treatment, usually for 9 to 12 months. In lung TB or lung TB, treatment sometimes might be prescribed for 6 months, but in TB involving the bone or the spine, we extend the treatment for 9 to 12 months so that there is less chance of recurrence because of the proximity of a neural tissue. And non-responsive patients should be screened for other possible diagnoses like tumors. The spine tumor can mimic TB spondylitis. TB bacilli are difficult to be isolated and they are slowly growing, and a patient not responding to anti-TB treatment should be screened for a possible resistant microorganisms, and there are second and third line drugs that can be used to treat these patients. TB can involve the neural tissue either directly because of the inflammatory process, or indirectly because of the instability of the skeletal or surrounding skeletal elements, yani instability of the spine, or because of the compressive effects of the infected or inflammatory tissue. Etiology of neurologic deficit involve two types. A patient with an active disease might present with a neurologic manifestations or neurologic symptoms or neurologic deficit, and this is usually due to the mechanical compressive effect of the inflammatory tissue. So the patient might have a neurological deficit because of the mechanical pressure, TB cold abscess. A patient with cold abscess that is causing pressure symptoms or neurologic manifestations is indicated for drainage. An infective granulation tissue might cause in compression or inflammation around the spinal cord or the neural tissue, and the patient might present with neurological deficit. Tubercular debris and sequestra might press on the spinal cord or the neural tissue, and caseous tissue again might compress there. So these patients with neurological manifestations in the early stage or the active stage of disease should be treated even empirically with anti-TB treatment, and if the patient is stable, we can wait for 3 weeks to monitor the response of the patient. If the patient is not responding to treatment, then surgery is indicated. Now, we shouldn't forget, as we said, TB can involve neural tissue directly, or and in this way, it will cause neurologic manifestations. Or it is because of involvement of the skeletal elements, and involvement of the spine and the disc, and secondarily will cause either mechanical pressure on the cord or pressure and inflammation around the cord, yani inflammatory and infective granulation tissue and caseous material or the abscess might cause a pressure effect on the neural tissue, and this is secondary to involvement of the spine. So a patient with a neurological deficit might get involvement of the cord or itself, and inflammatory edema or direct affection of the meninges, yani tuberculous meningitis or TB myelitis or inflammation, and in this way the patient presents with neurological manifestations. Again, tuberculosis can cause infective thrombosis or endarteritis of the spinal vessels, leading to infarction of the spinal cord. And these are the possible causative factors or the etiological factors behind a patient with tuberculosis spondylitis and the neurologic manifestations. A second type of presentation is a patient with heel disease. That's to say, a patient who is undergoing treatment for TB spine, or is not treated and the patient is get healing by itself. Again, a deformity can develop because of the vertebral destruction, and deformity with the development of gibbous formation or kyphosis can cause a pressure on the spinal cord or the neural tissue, and the patient present with neurologic manifestations of a heel disease. That's to say, the TB process is no longer active. Now, we should bear in mind that even with treatment, with anti-TB treatment, the vertebral destruction can progress even with anti-TB treatment, because it is not just an inflammatory process. It may involve, again, ischemic necrosis of the bone and destruction, or the development of progressive chronic instability because of destruction of the stabilizing elements of the spine. And in that way, deformity may progress in spite of anti-TB medical treatment. And in that way, the patient will develop neurologic symptoms. So, gibbous formation or pressure on the spinal cord because of a transverse ridge of bone, or constricting scarring in and around the dura, all these can cause neurologic symptoms. These are neurologic manifestations of a healed disease. Since TB is an anterior disease, surgical treatment of tuberculous TB spine can be approached from anterior approach or posteriorly. What we mean by posteriorly is that we can reach the lateral aspects of the vertebral or the infected vertebral bodies from posterior approach. And in this way, we can stabilize the spine. We can stabilize multi-levels of the spine, because anteriorly we cannot span the metal or the fixation hardware because of the proximity of great vessels anteriorly. So posteriorly we can go posterolaterally, extracavitary approach, and we can approach the vertebral body with removal or decompression of neural elements. We can put a cage or bone graft anteriorly through our posterior approach, and we can stabilize the spine multi-level. Yeah, we can, for example, we can use 2 levels above and 2 levels below stabilization, all from a posterior approach. So surgery involves the debridement of the infective tissue, decompression, and spine stabilization.